So, welcome everyone to this our first HIV STI Echo for 2023. It's been tumultuous here, but we're after that roaring start. I am, as usual, Dr. Gregory Boyce. I am your facilitator for today's session. I am joined by a member of our expert panel, Dr. Jeffrey Edwards, and Conrad Mitchell, who is our coordinator. Welcome to everyone who's here. And we're going to start talking today about a topic that I was sort of racking my brain about it. So how do we start the year off? What should we discuss? And I realized, we haven't really explored, especially in the context of HIV and aging and all the other comorbidities that kind of accompany HIV, how it affects the brain. So I thought we should start off there having that conversation because it's a constant discussion and there's still a lot we don't know. And we will, I think, unfold some of that today. So I'm going to start sharing my screen. So apologies for the fact that you're seeing me on my phone. The camera's giving a little bit of a glitch, so we just have to replace that at some point in time. So I'm 9 by 16 today. 16 by 9. All right. So here we go. Just confirming everyone can see my screen. All right. So I am Dr. Gregory Boyce, and just want to acknowledge all the assistance from the University of Washington, ITech, as part of the Caribbean ECHO program, as well as the University of New Mexico. I have no conflicts of interest with respect to the material I am going to speak to today. And learning objectives, we like to think first of, we like to describe the pathophysiology and clinical features of HIV-associated neurocognitive disorder, or HAND, as it is referred to. We'd like to outline the various methods that are available for the diagnosis of HAND, and to describe how we manage HAND. So, when you talk about HIV in the brain, there are a variety of ways HIV can affect the brain, both directly and indirectly. So we can think of things like opportunistic infections, which probably come easiest to mind, things like cerebral toxoplasmosis, cryptococcal meningitis, PML, all sorts of different opportunistic infections that directly affect the brain as a result of immunosuppression, as a result of HIV. We can think about what should be the primary focus for our conversation today, HIV-associated neurocognitive disorder, and we're going to talk about what that is, and how we define it, and how we diagnose it. Cerebrovascular disease, primarily because you remember one of the things we spoke about earlier in the series of last year was the impact of HIV on atherosclerotic vascular disease, both cardiac and cerebrovascular. And cerebrovascular disease is actually one of the major risk factors for symptomatic HIV-associated neurocognitive disorder. And there are various psychiatric manifestations of HIV, some of which present with fairly marked mood symptoms or schizophrenia, disorganized behavior. But depression can also present with primarily cognitive deficits, and sometimes that can mimic a dementing process. Of course, substance use disorders, whether it's injection, non-injection, can affect cognition. Immune reconstitution syndrome, especially if it's happening in the brain, can because of inflammatory mediators being deposited in the parenchyma of the brain, can affect cognition, mood, and behavior. And drug neurotoxicity, both the drugs that are used to treat HIV, a famous case of course efavirenz, and drugs that are used in the management of opportunistic infections, or other comorbidities, especially non-communicable disorders that are beginning to dominate the lifestyles of persons living with HIV as they age. So let's talk about what is HAND. What is HIV-associated neurocognitive disorder? So it's a spectrum of cognitive, behavioral, motor, and autonomous dysfunctions associated with HIV infection. And it presents as what we call a subcortical dementia of varying severity. So first thing, what is a subcortical dementia? So on the image there, you see the brain roughly divided up into two parts: the cortex, which is the outermost layer, where a lot of processing takes place, and the subcortical region that contains things like the thalamus, the basal ganglia, the brainstem. The parts of the brain that are not associated with consciousness, but have an important role in things like movement and cognition and that sort of thing. So the subcortical dementias tend to present less severely than cortical dementias. And when you think about a cortical dementia, we think, so the poster child would be something like Alzheimer's disease. right, where you get marked disruptions in many domains of neuropsychological expression. So when you think about cortical dementia, think of those 4 A's: aphasia, which is inability to communicate or to speak; right? Apraxia, which is an inability to do things. For example, even though the limbs all work, paralyzed. So for example, something like buttoning your shoes, right? Tying shoes, right? In persons who have advancing cortical dementia, they lose these skill tasks, right? Writing, they lose these skills. Agnosia, which is an inability to recognize things. So for example, when the test I'm going to come to, you show a picture of something and you ask, what is this, right? And with cortical dementias, or even some advanced subcortical dementias, you lose that ability to recognize things. And finally, amnesia, forgetfulness. So subcortical dementias would be versions of these 4 things, but less severe. So difficulty in concentration, difficulty with attention, with memory, but not often, except in severe cases, to the extent of the cortical dementia, and slowed cognition, apathy, forgetfulness, that sort of thing. So when we talk about how the term HAND came to being, it evolved from an earlier term called HIV-associated dementia or AIDS dementia complex that was first coined around 1991. Now remember, 1991 was the first decade after the first case of HIV was diagnosed. It was the pre-ART era. There was no good treatment for HIV at the time. And HIV-associated dementia accounted for about 20%, affected 20% of persons living with HIV as a late manifestation of AIDS, where there was a progressive and irreversible, essentially uniformly fatal dementing process that would end in the person being bedridden and mute and incontinent and that sort of thing. Right? That would be the diagram to the pie chart to the left. Right? Now, the diagnostic criteria in those days would have included both cognitive function criteria, so in a bit certain neuropsychiatric manifestations, as well as motor criteria, right, or behavioral criteria. The newer classification in 2007, HAND, or HIV-associated neurocognitive disorder, had 3 different stages to it. ANI, which is asymptomatic neurocognitive impairment, whereby an impairment can be diagnosed with fairly intensive neuropsychiatric assessment, but the patient themselves is unaware that they are of any impairment. Then there's minor neurocognitive disorder, or MND, in which case the patient starts to complain, well, no, doc, I'm forgetting things, I'm having difficulty concentrating, I'm less productive at work, I'm more irritable, I'm missing meds, that sort of thing. And then there's HIV-associated dementia, which is the more severe manifestation of HIV-associated neurocognitive disorder. I want to draw your attention to those 2 pie charts, because one of the things that has been found by research is the rates at which HIV-associated neurocognitive disorder has now come to be known affect persons with HIV has not changed that much, both pre-ART and post-ART. So if you notice, it's about 20 to 50% of all persons with HIV, and that purple part on the left is about the same, right? Slightly less in the ART era, but not that. Right? You would notice that there is much less HIV-associated dementia. So instead of 20%, it's now like 2 to 8%. It's much less. But there is a lot more neurocognitive impairment, a little more minor neurocognitive disorder. But the amount of persons that are affected is roughly the same. So essentially what has happened is that antiretroviral therapy has prevented the persons in these 2 domains, ANI and MND, from progressing to AIDS dementia, HIV-associated dementia, but the over proportions over time have not changed. And that is surprising, because you would think that with antiretroviral therapy, with opportunistic infection rates going down, and death rates going down, this part has not changed as much as what we would have thought with the advent of antiretroviral treatment. So how do we diagnose the 3 different domains of HAND. So with ANI, asymptomatic neurocognitive impairment, again, it's about 20–50%. This chart says 30%. There has to be impairment in 2 neurocognitive domains. And we'll get to how we assess that in a later slide. So there has to be more than one standard deviation of impairments in more than 2 domains, whether it's motor or cognitive or visual spatial or different domains that is significantly different from the average population matched by age, right? In mild neurocognitive disorder, again, there has to be same impairment in 2 domains, but the patient is not aware that there is an impairment. In ANI, they're not aware. You can pick up the impairment, but the patient is aware of it. Once the patient has symptoms, you go from ANI to MND. And with HIV-associated dementia, which is, again, the least common, less than 10% of all persons living with HIV will progress to this. There is marked, meaning more than 2 standard deviations, quite a lot of impairment in, again, more than 2 domains. And there is a marked interference in daily function. Right? The person, in all likelihood, would not be able to function independently without some sort of external support. So as I said, HAND affects 20–50% of persons with HIV. The risk for acquiring it increases with advancing age. With CD4 near there, meaning with your lowest CD4 count, the lower your CD4 count is allowed to drop, the more likely you are to have developed a neurocognitive disorder related to HIV. And also the length of time during which a person is virally unsuppressed before commencing ART. Now, since treat always starting everyone on first day and same day start, most persons who are diagnosed with HIV, once they present to care, are now started on treatment right away. It was previously the case that sometimes persons who had presented prior to treatment may have been in care, but not on antiretroviral therapy for an extended period of time. So that length of time tends to make it more likely that inflammatory disorders will start to cause neurocognitive impairment. HAND is potentially treatable, so antiretroviral therapy attenuates the symptoms or sometimes completely eliminates the symptoms of HAND. But patients with baseline neurocognitive impairments are more likely to progress to symptomatic cognitive impairment over 10 years, 2 to 6 more times likely than another person with HIV who had no impairment at baseline. So it doesn't completely dissipate the progression of neurocognitive disease, but it does slow it significantly. And as I would have stated before, we see more neurocognitive impairments in persons who start antiretroviral therapy late, meaning at lower CD4 counts, or late, meaning long after initial diagnosis versus early. So how does HIV affect the brain? What are the proposed mechanisms? So there are several. One of the most popular theorems is the so-called Trojan horse theory, whereby infected CD4 cells, macrophages, monocytes that migrate through the blood-brain barrier into the brain that have active virus in them, then would then release active variants into the brain itself. There was also some suggestion that some of the proteins related to HIV, like P53, P24, something called TAP, actually are injurious to the integrity of the blood-brain barrier, which makes it more porous to transmigration of virus directly into the central nervous system past the barrier. So what the blood-brain barrier is essentially a series of cells around the brain that are very tightly packed together so that it's very difficult for substances, even drugs, right, to penetrate into the brain itself, right? So that for the virus to actually get into the brain, the first thing it has to get through is through this barrier. Now, it is also thought that inflammatory mediators themselves is injurious to the integrity of the blood-brain barrier, and it makes the barrier more leaky, more porous. So, for example, when we speak about HIV as a chronic inflammatory disease, and all these inflammatory mediators affect the integrity of the blood-brain barrier. So, once HIV enters the brain, and we have all these infected cells now fighting against HIV in the brain, because there are immune cells in the brain themselves, right, that carry receptors for HIV, like microglial cells, like macrophages that are around the blood vessels in the brain that can be infected with HIV, that can release HIV, and then that can fight HIV. So it creates a very toxic environment because of all these inflammatory mediators for the cells in the brain that may not be directly susceptible to HIV infection, like the nerve cells themselves, like the so-called astroglial cells that provide the wrapping around the brain cells, that those, because the brain, the milieu in the brain becomes inflammatory, it can actually become injurious to those cells. The synapses can actually be injured and get fewer connections. That in and of itself is the functional marker for impaired function, right? So you can get neuronal damage and actually some neuronal cell death. And once you're getting injury to cells in the brain, then you have impaired function, right? Now, it is the case that in starting antiretroviral therapy can actually dissipate a lot of these inflammatory changes, but even so, they have found that neurocognitive impairments can sometimes persist despite complete resolution of the inflammatory changes. And what they also believe is happening is that the metabolism of certain cells in the brain changes in such a way that it is injurious to the function of those cells in the absence even of these inflammatory changes. So it's not just about inflammation, and we're starting to understand that a little bit better. It is also thought that HIV proteins themselves can be toxic to certain cells, certain neuronal cells as well, separate from the inflammation part, because the presence of these proteins in the brain is injurious to nerve cells. Now, one important issue that has come to recognition is that the blood-brain barrier itself, because it is differentially penetrated by anything, including drugs, as you mentioned, certain drugs that we use to treat HIV do not penetrate the blood-brain barrier as well as it should. So you can actually get almost like an oasis in the body, whereby the virus can get a relative shelter from certain drugs. So there is sometimes the case, and we'll come to this called CSF viral escape, where you have the viral load in the cerebrospinal fluid, that's the fluid around the brain, is actually higher than the level of HIV in the blood. They have undetectable virus in blood because the person is taking their meds, the serum concentrations of the drugs are high enough to suppress virus and that undetectable virus in blood. But yet, if you take a sample of the fluid around the brain, you can actually detect virus in that fluid. And that is thought, in some cases, even though not uniformly so, that higher levels of CSF, of HIV virus in the cerebrospinal fluid can sometimes be linked to progression, to onset and progression of neurocognitive disorders, even in the presence of undetectable serum viral loads. So what does it look like under a microscope? So the hallmark feature is inflammatory changes, HIV encephalitis. It's not so evident here, but all the little dark purple spots that you're seeing. This is a slide of brain tissue. Really dark purple spots are actually inflammatory cells that are peppering the brain, fighting off HIV. And that constant fight is actually injurious in brain to brain function. That's very widespread disorder. The other manifestations sometimes is what we call multinucleated giant cells. So a white blood cell with lots of different nuclei in it. And so these things, once they see on biopsy, are the histologic calling card for HIV encephalitis and neurocognitive disorder. And as I said earlier, the changes can resolve partially or completely with antiretroviral therapy, but impaired may persist even in the absence of these changes under the microscope. So let's talk about diagnosis. How do you diagnose HAND? So it is primarily what you call a clinical diagnosis, meaning there is no single test you can do that will confirm the diagnosis, whether you do a scan or a blood test or take fluid from the brain. None of those tests is specific enough to state if your serum XYZ is more than 10, you have this. So if we see this change in the brain, you must. So with a lot of cases of HAND, we make the diagnosis based on the history with the patient, examination findings, doing these neuropsychiatric evaluations when it comes to. So in terms of how the person will present clinically, once symptoms occur, remember the first stage, the patient is symptomatic. With second stage, MND, there may be some slowing of cognitive function, how difficulty processing, doing complex tasks, multitasking, maybe difficulty with memory, attention, and focus. As the impairment progresses, there may be psychomotor slowing, meaning that they actually do skilled physical tasks less well. So, for example, they may find that they're typing more slowly, or their fingers more clumsy if they have to play an instrument. Something has changed in terms of their dexterity, right? Again, you may get mood symptoms like depression or irritability. 5 to 10% of patients will have seizures. And the last stage is actually dementia, where the person is essentially lying in bed, unable to communicate, unable to manage the activity of daily living. But there's never a change in level of consciousness, except at the most advanced stages. There's never any focal neurological changes, meaning you never have somebody manifesting like they have a stroke, where they can't move their arm, or their face is drooping, or something like that. Right? That would imply a different diagnosis. And there's never any neck stiffness with HAM. Right? That would give us a different diagnosis, some sort of meningitic process. And there's never stuff like fever or chills or signs of infection. Right? So, in terms of how you would make the diagnosis of the cognitive decline, you would do various neurocognitive tests. So there's screening tests that I don't want to say the average Joe, but non-specialists can administer. So, for example, the clinicians will know about the mini mental state examination. This is the Montreal Cognitive Assessment, or MOCA, which seems to be the best neurocognitive test into the sensitivity with HIV-associated dementia, better than the MMSE, better than the IHGS, which is the International HIV Dementia Scale. But still, none of these tests are specific enough to clinch a diagnosis. Right? So it will detect clinically evident cognitive dysfunction, but not, as I said, able to distinguish, for example, HIV-associated neurocognitive disease versus mild Alzheimer's or Parkinson plus syndrome, where there's cognitive impairment. It would just document there is some level of impairment. Right? Now, the performance may fluctuate over time. So if someone would administer this test repeatedly to someone who's suffering from neurocognitive disease, you may get a different result every time. A little better some days, a little worse some days, but it tends to stabilize over time in someone who's on treatment for several years before there's any evidence of progression. Now, the gold standards for neurocognitive assessments would be some of these really in-depth neurocognitive assessments. And this generally is done by persons with specialist training, either neurologists, psychologists, psychiatrists, because it does require a significant degree of skill and training, both to administer the test and interpret the test. So it would be sort of a second level. If you refer someone to a specialist for further evaluation, this would be the sort of testing you would do, and you see there's a lot of them. So whether it's executive function, working memory, attention, processing speed, there's one. I couldn't fit everything on a page, for example, but it's a motor function. There are things you can do to assess these things. Right? And it would, of course, be sensitive enough to pick up the person in the first stage of asymptomatic impairment. They don't even know they're impaired, but these fairly sensitive tests would pick that up. In terms of ancillary testing, so something's going in the brain, is there any way we can sort of take a peek and see what's happening? So we can think about things like imaging, like MRIs, but is the most sensitive test for that is clinically available for diagnosing HAND, but the appearance are non-specific. So we talk about these hyperintense signals, this kind of light gray area you see around the ventricles of the brain, which is the dark space in the middle of the brain. Again, not specific. The major differential here would be something like a viral encephalitis like CMV, but it would add, right, one little extra layer of evidence potentially. A lot of times when we do scans like this in someone who is presenting with altered cognition, the goal is not so much to diagnose HIV-associated dementia or neurocognitive disorder, but to rule other things out, like what we spoke about earlier with toxoplasmosis, or cryptococoma, or a stroke, or a bleeding brain, right? Because as I said, HAND, with these ancillary tests, there's no one test that will clinch the diagnosis. There are other imaging studies that are available, but not generally in clinical practice. Most of these things are done in research settings. What other tests can we do? So we can take a sample of CSF to see if there's any evidence of inflammatory changes. So you might see some mononuclear white cells, which is evidence of inflammation. You might see some, sorry, there was a little click there. We might see some bad elevations in protein or albumin or antibodies in the CSF that again are highly suggestive. CSF HIV viral loads can be done in certain settings. The difficulty arises that there is no consistent correlation between CSF, cerebrospinal fluid, HIV viral loads, and presence or severity of neurocognitive disorder, both in the pre-ART and in the ART era. So again, we use this surprising sort of finding that you could have HIV in the CSF and not necessarily have evidence of neurocognitive disorder. And the other reason why it's something more helpful is that an opportunistic infection in the CSF, in the brain, sorry, would actually trigger higher CSF HIV levels. So the specificity is not good enough to make a clear-cut diagnosis. In terms of serum biomarkers, so things that appear in blood at certain levels to see, well, is there evidence either of inflammation, nerve damage? There isn't any one marker or any combination of markers that's good enough yet to make a clear diagnosis, because this is important, because you want a test that will be able to tell you diagnosis. So if I do these groups of tests and A and B and C and D above this level, then this is what it is. Or if I do this group of tests at A and B and C and D change from level A to level B, then that will give me prognostic information. We don't have that yet, either with any of the tests that we have available for HIV-associated neurocognitive disorder. So differential diagnosis, what else do I think about in someone who presents with evidence of cognitive decline? So we spoke about other dementing disorders like Parkinson's plus, like Alzheimer's, major depression, that's the so-called pseudodementia, intoxication with any substance, opportunistic infections like PML, like toxoplasmosis, CMV encephalitis, lymphoma, infections like neurosyphilis, nutritional disorders like B12 deficiency, hypothyroidism is not a bit as important as well, and medication adverse effects that you almost must consider anytime someone presents with a change in medication. Go through all the meds they're on, because the older persons get the more susceptible to get to this, the longer the list of drugs are likely to be on. So you also have to rule out the possibility of a drug or drug interaction causing cognitive decline. So how do you manage neurocognitive disorder in HIV? First step, optimize the other co-occurring diseases or contributors to cognitive impairment. So for example, any cause of cerebral atherosclerosis, whether it's diabetes, hypertension, smoking, hyperlipidemia, needs to be managed, because those things will drive cognitive impairment. Mood disorders and other psychiatric disease, substance use disorders, any obstructive sleep apnea, which is not as broadly recognized as a cause of cognitive impairment than it should be. It's well documented. And any other co-occurring cause of dementia that could be happening along with HIV-associated neurocognitive disease. And we have to ensure the patient has robust support structures, because as the patient cognitive decline worsens, they are going to need other help in terms of just something simple as paying bills, taking their meds, and getting dressed, keeping their appointments. And I think all of us know cases in the clinic where patients are very challenged in terms of their ability to function, and they need a lot of help. So the definitive management is antiretroviral treatment, right? nothing else essentially has been proven to be helpful. Right? Whether it's anti-inflammatory medication, they've tried doxycycline, minocycline, lots of different things. Nothing has been proved to be helpful other than antiviral therapy. The question is, what type of antiviral therapy should we use? There is something called the CNS penetration effectiveness score that you see on the right. So the higher the number, the more efficiently that drug is able to cross the blood-brain barrier. So you see the drugs that cross the blood-brain barrier best are some old drugs, right? Zidovudine, nevirapine, indinavir, which we have used in years. Dolutegravir, thankfully, the integration inhibitors are all in the bottom there. Some of the nucleosides like abacavir, picitabine, didanosine, tenofovir, don't penetrate the blood-brain barrier as well. So the question is, in someone who we suspect, let's say at baseline presents with cognitive impairment, do we try to assemble a regimen with the highest CPE score in order to presumably give them the best chance of resolving their disease? There is some evidence in favor of it, but it is conflicting. As a matter of fact, it was analyzed as recently as 2022, which is where this was taken from. We still don't have a good idea, based on the quantity of research available, whether or not we should be tailoring antiretroviral regimens to neurocognitive disorders. The European guidelines, the American guidelines do speak to, for example, if there is evidence of CSF viral escape, especially if you can do resistance testing on CSF, which is not easily available, and you can see that there's some compatibilization, there's a different strain in CSF as in plasma, then you can change drugs to suit. But that's out of the reach for most treatment sites in developing world. So there's a few final questions in terms of how we deal with neurocognitive disorders. So do we screen? Do we do a mini mental state exam or a MOCA on everyone above, or do we do it on a person above the age of 60? Do we do it above persons who are having signs of cognitive impairment? And when do we do it? Do we do it annually? Do we do it every 5 years? And who does it? Doctors, nurses, allied staff? How do health systems ensure equitable access to diagnostic tools? Because some of the tools that we listed are available essentially in research facilities only, or very high-powered centers. And given that most of the 30 to 39 million persons with HIV are outside of those centers, and we're seeing half of them could be suffering from neurocognitive disorder, how do we get them access to the diagnostic tools they need? There are research gaps in identifying better diagnostic and prognostic biomarkers and the diagnostic tools in general. It would be a wonderful thing for someone to walk into and get a blood test and say, okay, you have some sign of cognitive, that you may be at risk of cognitive impairment. Let's talk about how we put things in place now to preserve much brain function for the next 30, 40 years, because you're going to be here for 30, 40 years, rather than wait for symptoms to develop. And there is a need to update those penetration scores for more recent drugs, right? Dolutegravir, but some of the newest drugs, for example, abacavir, rilpivirine injection drugs, some of the newest drugs that are used in the most advanced drug resistance cases are not there. So that, I mean, the list will be 10 years old to next year. So we do need to update it. So in summary, HIV-associated neurocognitive disorder remains common even in post-ERT era. Early HIV diagnosis and prompt commencement of treatment is critical to preventing and reducing progression to symptomatic disease, and better diagnostic and prognostic markers are needed to prioritize treatment. And that is the end of my presentation. I thank you for your attention. Open the floor for some questions if anyone has anything you'd like to ask about anything at all about
it. I think, Conrad here, I think one of the things that really sticks with me is how so many of the symptoms could be everyday stuff that we see. So how do we really kind of do we worry about this as PLHIVs, or is it just that we make sure that we check fit each time? What do we do? Greg, I think you're muted.
Can you hear me now?
Yes, yes, I can.
Right. So I was kind of chuckling to myself when I was doing this presentation because I'm always forgetting where my keys are. This morning I had to deliver a message to someone I couldn't remember what it was for 3 hours. So it's like, how do we tease those sort of, I guess I'll forget things here, versus actual neurocognitive impairment? That's where those screening tools come in, right? So that's why I asked the question, who do we screen? If someone says, I'm a little forgetful, do we just, oh, you forgot your keys? Well, sit down, let me put you through this 110 question neurocognitive assessment, right? They are simpler tools, but I think there's a conversation we need to have. And it's a question we need to start asking, right? Are you having difficulty functioning at work? Are you having difficulty doing simple tasks? Do you find that you're slowing down? Have you noticed changes in how you're able to function and process? And that might be the trigger for starting the cascade of let's get an assessment but actually let's start formalizing how we assess you and move towards a diagnosis if necessary.
And would that also be triggered by a person's age versus a person's length of time on HIV? And if so, which would be the greater kind of determining factor?
So it's both to a certain extent, right? So both age and length of time. But let me correct that slightly. Length of time during which someone is virally unsuppressed. So if someone has been in care for 2 years but has been on medication from day one, that's not quite the same as somebody who, let's say, found out 10 years ago, didn't come back for 9 of those years, started treatment and is now suppressed, right? There'll be a great exposure of the brain to viremia and all the inflammatory components that go along with unchecked viremia. So again, I think that's a good question that we just sort of figure out, especially in places like here and the Caribbean. Are we doing enough to actually make these diagnoses and refer our patients and think about how we're going to manage moving forward, rather than when someone manifesting with the most severe presentation, can't remember when the appointments are, can never remember the pills, and we're not trying to work backwards to figure out what's happening.
Great, thanks for that.